Good evening, ladies and gentlemen. My name is Russ Thomas, and I'm the CEO of Prostate Forum of Orange County. Before we get started, I'd like to make a couple of announcements. Prostate problem people have to know where the bathrooms are. So, go out the door that you came in, make a right. Both ladies and gentlemen bathrooms are on your right as you go out the door. We do have to support the expenses of our work, and if you can help, we'd appreciate it. We do get about half our expense money from your generous donations, and the rest comes from donations from our local community. I have a couple of board members that will pass the basket that I have over on the piano, just like you were in church. John, would you grab a basket? And would I have our board members please stand up so that the people here know who you are? Larry, I know there's more here. Okay, and thank you very much. The reason I want them to stand up is because these are the men that give selflessly of their time without compensation to provide the help and support that you need with prostate problems. Thank you very much, gentlemen. We appreciate it. If you can hold your questions during Dr. Meyer's presentation until after he's done, then we will take questions over here at the piano and we'll have a microphone with you because our questions that come from the audience aren't picked up properly by our DVD that we're recording here. So hold your questions until the end. After the question and answer session, there are generally people that like to ask personal questions of the doctor. Unfortunately tonight we're not able to do that because Dr. Myers has a plane to catch. And he's leaving directly from here to the airport. So he won't be able to talk to you personally tonight. To you, Dr. Charles Snuffy Myers. Dr. Myers graduated near the top of his class from the University of Pennsylvania School of Medicine in 1969. He decided to focus his research on the process of cancer, drug discovery, and development. He was particularly interested in using a process called clinical pharmacology to devise ways to make cancer drugs safer and more effective. In 1974, Dr. Myers joined the staff of the newly formed Clinical Pharmacological Branch at National Cancer Institute. By 1984, he had become chief of the Clinical Pharmacology Branch and remained in that position for 10 years. During his years at the Clinical Pharmacology Branch, Dr. Myers made a number of contributions to cancer research. With over 250 research papers published, Dr. Myers' major activities revolve around prostate cancer treatment and research. His laboratory research was focused on why a diet high in animal fat appears to foster progression of prostate cancer. His research group demonstrated that a fatty acid, arachidonic acid, commonly found in meat, dairy products, and egg yolk, promotes the survival and growth of human prostate cancer cells. This can be explained more completely in his book, Eating Your Way Through Better Health. This book can be purchased either in his website, prostateforum.com, or on amazon.com. As a leading prostate cancer specialist, Dr. Myers offers a non-biased look at all available treatments. With no vested interest in surgery or radiation, Dr. Myers makes his analysis based on the available science, period. As a prostate cancer survivor, however, Dr. Myers translates his experience from both sides of the examination table into one of the most unique and sought-after perspectives in the prostate cancer field today. Dr. Myers has long been popular among prostate cancer patients as a speaker because of his ability to explain science and medicine in an easy-to-understand language. As I have previously mentioned, Dr. Myers is himself a prostate cancer survivor. When he was diagnosed in 1999, he was 55 years old. His PSA was over 20. His Gleason was a 7 on his left side, and the cancer had spread to his seminal vesicle on that side and had leaked into the lymph nodes in his pelvis. There were cancer cells in his bloodstream, bone marrow, and in both sides of his pelvis. The cancer had clearly escaped the prostate gland and had spread everywhere. According to the consensus of his colleagues, he would be sick with advanced metastatic disease within 5 years, and he would be dead in 10 years. I won't go into the very aggressive nature of his treatment decisions, but you can read about it yourself by purchasing one of his many books called Beating Prostate Cancer, Hormone Therapy, and Diet. It is also available on his website, prostateforum.com, or you can get it at Amazon, or you can even rent it from our library right outside the doors here. Today, his cancer is undetectable. It is with extreme pleasure that we present to you the very much alive Dr. Charles Snuffy Smith.
When I hear you tell that story, I still get nervous, you know. So before we get started, on an ongoing basis, to make sure everyone keeps up to date on the disease, I do video blogs every week, and we have a sign-up sheet outside at our desk. So if you just sign on, put your email, and we'll email you the video blog each week. And they're 5-7 minutes long and try to cover a key topic that patients are interested in or that I think are newsworthy. How many people were at the PCRI conference? Enough that I'm not going to duplicate that talk then. So instead I'm going to take a different tact. And I was supposed to talk about a rising PSA at the PCRI meeting, but I took the advantage of seniority to talk about something else. So I'll talk about how we look at a rising PSA after surgery or radiation in our clinic, and take you through a step-by-step process. And this step-by-step process has radically changed the death rate for prostate cancer in our clinic. As I mentioned at the PCRI meeting, I average 1,100 patients in our roster on a yearly basis, sometimes somewhat more, sometimes somewhat less. And in 2010, we had 24 deaths in a group of patients with recurrent prostate cancer. So it's an uncommon thing for a man in our clinic to die. And those 24, not all of them died of prostate cancer. Cardiovascular disease was also a major killer. And I think there were 1 or 2 cases of Alzheimer's as well. So we're at the point now where we don't have to struggle desperately to keep most patients alive, and we can afford to ask the question, what is the least damaging way of keeping the cancer in check? How can I optimize the quality of life of a patient while keeping the cancer in control? And so this has led to a very different way of approaching recurrent disease. Now, if you've had surgery, for example, and your PSA is rising, one of the first things you may be presented with is radiation therapy to your prostate bed, which generally works about half the time and compromises sexual function and urine control in many men. And so that hardly seems like a great deal. So our approach is quite different. When we see the rising PSA, the first question we ask is, can we arrest the progression of this disease without causing significant side effects? And I maintain a menu of drugs and supplements in my head that are known to slow the progression of prostate cancer, and develop a cocktail for each patient. We'll talk about some of these agents in a minute. But first you need to know what the PSA doubling time means in this age group to understand what our goals are and what success looks like. And I think the best data set of what the PSA doubling time means in a man who's had surgery or radiation therapy comes from Johns Hopkins, where for most of his career, Pat Walsh advocated no treatment for recurrent disease because he felt that if surgery didn't work, nothing else did. So it's a huge patient population that were managed with no treatment with a rising PSA. I remember one patient came to me from their clinic with a PSA of 1,000 and hadn't been treated because he hadn't had bone pain yet. So no matter what you feel about how wise that was, it's an interesting insight into how this disease behaves. So if the PSA was taking longer than 18 months to double, prostate cancer didn't appear as a major cause of death compared to heart disease, hypertension, and diabetes. If the PSA doubling time was slower than 9 months, but faster than 12 months, at the end of 10 years, around 5% of the patients had died. Still, that's really slow, and that's with no treatment. No treatment, over 10 years, you only lose 5% of the patients. So if the doubling time is between 9 and 12 months, the chickens come home to roost between the 10th and 20th year. So it gives you an idea of how already slow the pace of the disease is. Now, if the patient sitting before me is 85 years old and has uncontrolled hypertension and low blood sugar, the odds of him living long enough to get in trouble with prostate cancer is nil. So there'd be no justification for any treatment that would compromise his health. If the doubling time is faster than 3 months, you're dealing with a form of the cancer which is lethal in 90% of the patients at 10 years. So think about that. Between 3 months and 9 months, you encompass something that is 5% mortality at 10 years versus 90% mortality. So shifts within that range, you should take someone with a doubling time of 3 months and shift them to 9 months. That's a revolution in their survival. So the details of the PSA doubling time turn out to be really, really important. And if you accomplish a major slowing of the disease growth, then you can often create a circumstance where the patient will live out their life and die of something else without ever having encountered any serious side effects from treatment. So how do we approach this? Now, I'm going to start with the simplest and least intrusive tools and then move up to several that are more and more aggressive. The first thing we do is advise people to switch to a Mediterranean heart-healthy diet. Why the Mediterranean heart-healthy diet? Well, the truth is, first and foremost, my wife is a Sicilian extraction. And if I recommended anything else, I'd probably sleep with the chickens. But it's the diet that's been best studied. In medicine, we look for randomized control trials, placebo versus treatment. And the Mediterranean diet is virtually the only diet that's been studied repeatedly for heart health, diabetes, obesity, The most recent, the past year, they showed that it doubled the survival of patients with Alzheimer's. So it slows the progression of dementia. So this therapeutic benefit is clearly demonstrated. On the other hand, it's also a very tasty diet. Think of a Greek restaurant or an Italian restaurant, and you happen to live in a state with a Mediterranean climate in the vigorous agriculture, so food for a Mediterranean diet is widely available at all the grocery stores and might help your state debt. I just have to give you an aside. I come from Virginia, and we have a budget surplus. Just let that rub in a little bit. I'm not gloating. So Mediterranean heart healthy diet, and the clinical trial that tested this in prostate cancer was at University of Massachusetts in Worcester. And it took a group of patients who recurred after surgery, and the median PSA doubling time was 6.4 months. So like halfway between 3 months and 9 months. A disease that also has a high mortality rate. When they switched them from an American diet to the Mediterranean diet, the doubling time went from 6.4 months to 17.7 months. Such a large shift that the patients now had a doubling time that would make the cancer not a likely cause of death compared to hypertension, diabetes, and so on. So basically took the cancer out of the range of something likely to cause the death of most of the patients. Something simple that's good for your general health, doesn't require a doctor, just a trip to the grocery store. It doesn't require you to eat ice cubes and styrofoam. It's not an extreme diet. There are other more extreme diets that will slow prostate cancer down, but offer no added benefit. The macrobiotic diet will slow prostate cancer down, but you're eating seaweed and you can't have tomatoes and so on. And that diet causes B12 deficiencies. Dean Ornish's vegan low-fat diet will slow the cancer down, but you can't have any animal products and you can't have any oils. So you're basically on grains and legumes, and it's a very sparse diet, hard to stick to, and not necessary. And so what are the key parts of this diet? We now have enough information on the Mediterranean diet to hone in on the key things here. The most important thing is to give up red meat, particularly grilled red meat. That's like playing Russian roulette with all chambers loaded. Of the 24 patients I lost last year, more than half of them would not give up red meat. Basically what I see in patients who continue to eat red meat is I can get the cancer under control, but I can't hold it. The cancer will escape control. Bacon is the single most lethal food you can eat for prostate cancer. It increases the death rate by 700%. And cured meats in general are a good idea. Cold cuts. Turkey bacon is still a cured meat. So you really want to avoid that. The other key part of this diet is you need to avoid corn products. So no cornmeal, corn chips, popcorn, because they contain an omega-6 fatty acid that can make prostate cancer grow explosively. To give you an example, I had a patient whose PSA was doubling every 9 months for years. And all of a sudden, it started doubling every 2 weeks. That's a big jump, 14-day doubling time. So I called and said, well, what's changed in your life? And they said, well, I've been watching, my wife and I after dinner watched the Turner Classic Movie Channel, and I have 2 bags of Orville Rickenbacker popcorn. And that was it. When he stopped the popcorn, the doubling time went back down. So again, these little details matter. You can have all the fish and shellfish you want. You can have non-fat dairy, although I prefer soy milk. You can have egg beaters, egg whites. While it's low in animal fat, you can have all the almonds and pistachios and cashews that you want, hazelnuts. avocados, olive oil, dark chocolate. Red wine is part of the program. So as I say, it's not styrofoam and ice cubes. So this is the most important single thing to do. There are 4 supplements that, there are many supplements out there that are reported to affect prostate cancer. We've tried to limit it to 4 that have the most activity because people get tired of pills. And so the 4 ones we use are vitamin D, and we target the vitamin D level you would see in a Caucasian male in a swimming suit in the summer sun, which is 60 to 80 nanograms per mil. So we measure the vitamin D level every month and adjust the oral dose to people get in that range. Pomegranate extract capsules, resveratrol, curcumin. Those are the 4 supplements. And they're chosen because they all have cardiovascular benefit as well. Resveratrol particularly does 3 things that are of major health importance. It will improve your good cholesterol, the HDL cholesterol, sometimes dramatically. It tends to reduce systolic hypertension, or make it less severe. And it improves blood sugar in people with an elevated blood sugar. It does all these things without lowering the blood pressure too low or lowering the blood sugar too low. And so it affects several of the other major diseases that people get. And so it fits the definition of a program that enhances general health while controlling prostate cancer. For many patients, that's all that we need to do. However, some patients need extra, and the first drug we would use, prescription drug, would be Avadon. There are 2 forms of testosterone. There's testosterone and dihydrotestosterone. Testosterone is what your body makes, and then dihydrotestosterone is made from testosterone. And the dihydrotestosterone does 3 major things: male pattern baldness, acne, large prostates. And Avadon blocks that conversion. So testosterone actually goes up. 25 to 30%, your testosterone would go up. The dihydrotestosterone falls. Our goal for the dihydrotestosterone is under 5. This will routinely slow many prostate cancers down because dihydrotestosterone is needed for the cancer to form new blood vessels. So it's a very safe way of selectively cutting off blood flow to the cancer. Makes a very handy drug. What about side effects? Well, before I start talking about side effects, I would mention that Avadon was prohibited in the Olympics. It was tested because it's a performance-enhancing drug. Because it increases testosterone, it improves muscle power and strength. So I get a big charge. There isn't often a medical oncologist who gets to prescribe a performance-enhancing drug, and this does that. Because of the increased testosterone, it also improves bone density. So it's a form of hormone manipulation that has many benefits. 2 side effects that need to be looked for. One, about 20 to 30% of the men will have a drop in sex drive. That can be temporary, but sometimes it continues as long as you're on the drug. And so if that gets to be an issue, we tell patients to either reduce the Avadon dose or stop it altogether, depending on the impact that has on their lives. For many men that are coming post-surgery or radiation, sexual function is a thing of the past anyway, and so they don't mind this, but more and more the surgeons are getting better and more men are retaining sexual function. And there are people who experience a decrease in sex drive. We do Avadon every day for the first year, and then begin to taper the Avadon to Monday, Wednesday, and Friday, Tuesday, Thursday, and in some patients once a week. Find the lowest dose that's needed to control the dihydrotestosterone. And during that phase, when we've tapered the dose, the impact on sexual function tends to be minimized. People do better on that. So that is a program that I would say is about as intense as I like to go in most patients. There is a drug, Celebrex, approved for arthritis because it's safer than aspirin, that will slow prostate cancer down. But your cholesterol and blood pressure have to be perfect for it to be completely safe. Celebrex can make hypertension a bit worse. If your cholesterol is elevated, it will make the threat that high cholesterol poses to your arteries more severe. Well, this fits well with our first approach because we put you on a Mediterranean heart-healthy diet, and we're going to be looking over your blood pressure and cholesterol like a hawk. During the early phase of treatment, while we're doing the Mediterranean diet and supplements, we'll be looking at your cholesterol and seeing how it responds to diet, and put you on a statin if the diet doesn't work, and if your blood pressure doesn't come down with the diet and general healthy program, we'll put you on drugs to lower your blood pressure. So our goal is to minimize cardiovascular disease because it is such a problem in men with prostate cancer. And we're doing so well with the cancer, I don't want you to make me look bad by having a heart attack. So that's the growth arrest program. In some patients with very rapidly growing disease, we use special drugs that I won't get into tonight. Now, what happens if your PSA continues to rise? Well, this whole thing has changed because we now can identify where prostate cancer is located in the body. And what we're finding is that most of the men come to us with a PSA-only recurrence. The cancer is in fact in the lymph nodes in the abdomen and pelvis. If we could only find it, we could get rid of it. The Prostate scan was the first go-around with this. And the Prostate scan had its uses. There were 20% false positives and 20% false negatives, so that was a problem. The next up was the Comedex scan available in Europe. It was an MRI scan. It could spot cancer in lymph nodes down to 2 millimeters in size, and it was a wonderful reagent. I sent about 50 patients to the Netherlands, and it was highly effective at finding the cancer if the PSA had reached 2. I'll give you an example of how it affected my practice, and it's one of the reasons why the death rates in our practice have suddenly dropped. This is a man, a real estate developer from Washington, D.C. I had a radical prostatectomy, cancer came back, PSA doubling time was pretty fast, faster than 6 months. I can't remember if it was faster than 3 months or not. But he, over the years, became resistant to hormonal therapy, second-line hormonal therapy, and finally, the only thing left was chemotherapy. So we were sitting there, his PSA was under 1 at the time, but we knew that he and I would just have to sit and watch this PSA until we got uncomfortable enough to put him on chemotherapy. So it was not an unpleasant time for him. And then the Comedex scan became available, and he went to the Netherlands, and they found that despite being hormone resistant, his cancer was in a cluster of nodes in the left side of his pelvis, along the iliac artery. And that's an area that can be irradiated safely. So I sent him to Michael DeToli in Sarasota, Florida, who irradiated those lymph nodes. That was finished 3 years ago. His PSA went undetectable and his cancer's never come back, and he's not been on any treatment for the last 3 years. With his last visit, he had a penile implant put in place and was mainly talking about implementing a sex drive with a new partner on a vacation to Siesta Beach in Florida. So it was a great meeting. So this man's life was transformed. Not only does he not face progressive prostate cancer and death, but he's put the disease behind him. And now we can deal with repairing the damaged treatment cost. So that's the promise that this offers. Unfortunately, the reagent, the imaging reagent, that is used for the Comedex scan is no longer available. The company that was making it in Europe has financial difficulties, as many companies do in Europe. And so they closed down. And there was a period of time when we had nothing available. Fortunately, Stephen Bravo at Sand Lake Imaging in Florida was interested in filling that niche. And he showed that a different imaging agent called USPIO ferraheme would also be picked up by the lymph nodes. And so this is an iron-containing imaging agent. And you infuse it on one day, and then 24 hours later, the iron will have been taken up by the lymph nodes. He then puts you in a magnetic resonance imaging machine, and of course iron impact is visible on magnetic resonance imaging. And he's able to image all the lymph nodes in the body. Cancer doesn't take up iron, so it shows up as an iron-free defect in the lymph nodes. And so this is similar to the way the Comedex imaging operated. The USPIO ferraheme is not quite as good as Comedex, but almost as good. And his resolution is 2 to 4 millimeters rather than a solid 2 millimeters of resolution. Nevertheless, this seems to be enough. And at this point, I've sent about 200 patients to Sand Lake Imaging in the past year. Michael Dottoli, who's on the other part of the Troika working on this, has sent 300. So we've got a database with about 500 patients that have gone through this. And about 70 to 80% of the time, if the PSA is above 2, you can find the cancer. And if you then irradiate the lymph nodes that have taken up, that show up on a ferraheme scan, more than half of the patients' PSA is undetectable. Now, this is still too new. I can't tell you how the patients are doing 5 years from now. So I can only tell you that it is imaging cancer, and then when you irradiate it, the PSA goes down. But the promise is that patients recurrent after surgery might be cured. So I'm very excited about this. And I think this kind of thing is, normally the progress was growth arrest that we were doing. That would work for a while, then you need hormonal therapy, and then that would work for a while, then you need chemotherapy. But eventually the game would play out. But now patients would be on treatments that were, with the case of hormonal therapy, a problem. So this short circuits all that and lets people walk out the door. Heavens knows I might have to retire because there's no more prostate cancer to treat. So while all this is going on, there was another line of work that started in the University of Rochester in New York State. The University of Rochester is a superb medical center in a part of the country without much in the way of medical resources. It's no secret that I think the care there is not very good. I would rate upstate New York as probably second only to rural Mississippi as the worst medical care in the United States. Simply atrocious. Even general medicine is simply unacceptable from what I've seen. So as a shining light in that region, they have a huge patient flow. And Edward Messing was head of urology, and Bill Diuretics, who was head of radiation therapy, decided to go back and review what happened to all the patients with PSA-only recurrence after surgery and radiation in this large data set. And they split people up into 3 piles. PSA-only recurrences, those with 5 or fewer bone lesions, and those with more than 5 bone lesions. And lo and behold, if the patient has 5 or fewer bone lesions, for the next 5 years, their survival was almost as good as the people with PSA-only disease. With people with more than 5 bone lesions, the cancer tended to spread rapidly to other sites. If there were 5 or fewer lesions, the bone involvements tended to stay stable. If you had 4 lesions now, a year from now you'd have the same 4 lesions. 2 years from now you'd have the same 4 lesions. So the disease appeared to get to the bone and then take a breather, arrest progression for a while. And this was a sizable number of patients in there. in their data set. So they took the next step, and in this great paper in 2004 said, well, this means that if we were able to kill the cancer in those 5 bone lesions, we would then create a situation where we would abort the subsequent explosion of the disease, and we might buy patients a prolonged disease-free interval. Well, as I said, this came out in 2004, but they were presented earlier in meetings, and so pretty early in the 2000, between 2000 and 2010, we began to take patients who had 5 or fewer bone lesions and irradiate their prostate gland, their pelvic lymph nodes, and the bone lesions, and put them on hormonal therapy. And I have a growing list of patients from that era that are remaining free of disease. In fact, about 80% of the patients we treated in this fashion who had 5 or fewer bone lesions have remained in control. You haven't gotten new bone lesions, haven't progressed. Again, it always helps for patients to hear an example of this. And there's a guy who lives 1 block from my practice. And in 2005, he presented with a PSA of 430, a Gleason 8 prostate cancer, and a metastasis to his 4th thoracic vertebrae. We did the usual thing, put him on our hormonal therapy program, drove him into a complete remission with a PSA of less than 0.01, and then did radiation therapy to his prostate gland, pelvic lymph nodes, and the vertebral lesion. 6 years later, his PSA is now finally broken 1, so he's getting a slow recurrence. But for 6 years, the disease has been in control. So you can see how this would transform the survival and quality of life of patients, even with bone metastasis. Now that is a big change. 10 years ago, you say bone lesions, and people would, say, well, you set the survival clock. You've only got so much time left. Now that has changed dramatically. So we call this in the field, this is called oligometastatic disease. Oligo for few. And what we're doing in prostate cancer is not new. It's just due to prostate cancer. This concept of some cancers spreading slowly to a few spots, and if you got rid of those few spots, the patient do well, has been something that has been known in the field since I came in the field in 1971. It was already well known in 1971. So there are certain cancers where this is the standard approach. Cancer of the adrenal gland that's metastatic. The treatment of choice is go in and take out the metastasis. You might have 20 lesions in your lung, and we'll pluck each one out, because then the cancer will take years to come back. Cancer of the colon that recurs, in the liver. If the cancer is growing slowly and there are a few lesions, patients do very well if the surgeon goes in and shells out each metastatic lesion out of the liver. In fact, there was a major review, the classic review of oligometastatic disease was written in 1995. And they laid out the principles for when this form of treatment would make sense. That is, the cancer had to grow slowly and spread to a limited number of sites that were accessible. Well, in retrospect, why didn't people think prostate cancer was something that is it's the slow-growing cancer of adult life par excellence. It should have been obvious years ago to all of us that someone should try this, but it took someone had to take the first leap, and Ed Messing and his crew at the University of Rochester did that. So I need to be thankful for them, because it's transforming advanced disease. So I'd like to stop here for questions on this before I go on to the next component. But this is how we approach recurrent disease after surgery or radiation.
Grant? Oh, there you go. If anybody has any questions, I'll bring the microphone to you. Larry?
Thank you again, Tim, for your appearance here, your presentation. In 2003, I had simultaneous radiation at RCOG, and I reached a low point in my PSA 3.5 years ago. Gradually, it rose to the point where I spoke with Dan Tolley, and he recommended that I have the USPIO, which I had in February of 2011.
He's talking about the imaging technique at Sand Lake, the USPIO ferritin. So he's someone who's done this.
So he went through the CT and the MRI with the imaging. Thank you. Can everybody hear me okay? Both of them told me that they couldn't detect any cancer.
What was your PSA at that point?
It was 0.45. And it's now 0.62. I'm due for another PSA here in about 2 weeks.
So in general, the ferritin technique success rate requires a PSA above 1. As the PSA above 2, as the PSA gets higher from that point on, the utility gets better. Around a PSA of 10, they can find disease in about 90% of the cases. Go ahead.
So I was thinking, and I collaborated with both doctors, that perhaps in a year I'd go back and have the lymph nodes re-scanned, okay, with the enhancement. Would that seem reasonable to you?
Yeah. So you're plugged into the system.
Yeah.
Good.
Anybody else? Yeah. And you just experienced with Larry, you have to hold this mic close, because if you hold it like this, the people around won't hear. So please hold the mic close.
I have 2 questions. The first is that I did go to the Netherlands, had Combinets, and had anaphylactic shock. What is your experience with anaphylactic shock with the new method of medication that you're using, or imaging that you're using in Florida? Iron-based.
We haven't had anaphylactic shock, but we've had some hives.
Great.
Yeah.
Second
But if
question.
you do enough of them, you're going to get it. Any injectable drug or contrast agent will cause anaphylactic reaction in some people.
Got it. I have a sodium fluoride PET scan recently that disclosed bone metastasis. I'm in my 7th year. My highest PSA was 2.8. I've been undetectable almost all that time. I can't reconcile those 2 symptoms, low PSA and bone metastasis in 3 places. At least the
for
PET
some
scan.
reason, I'm having great difficulty understanding what you just said.
Okay.
So do you have bone metastasis?
A sodium fluoride PET scan said that it appeared that I had bone metastasis in 3 areas of my spine.
Yeah.
I'm in my 7th year. I have been on hormone therapy and complete therapeutic help and immunotherapy, and my PSA has been maintained at very low levels going up until 2.8 earlier this year, and now I'm back to 0.04. But I don't understand. I thought that the bone metastases came after the development of PSA, and so I'm having difficulty reconciling that.
Well, you have a PSA. It was 2.
It was at one time, yes.
So, well, I think you have a confusion that's common among patients and unfortunately many urologists. One study looked at patients recurrent after surgery for bone metastasis, and out of 308 patients with PSAs under 20, only 1 was positive. So the appearance of bone metastasis with a PSA under 20 is not common. It does happen, but it's not common. It's less than 1% of all patients. But in fact, there are enough patients that we can actually talk about that with considerable precision. There was a review from Britain, Berteld was the first author, where they took a group of patients with bone metastasis and PSA under 10. And what they showed, this is in the British population, so the British undertreat, much less aggressive than here. But hormone resistance developed in half the patients within 7 months. So it's a form of the disease where hormone resistance can develop quickly. And resistance to Taxotere also developed quickly. So it's the kind of thing where you really need to get rid of it. So when we see 1 or 2 lesions develop with a PSA under 10, we call our friendly radiation therapist and make an arrangement for that lesion to be irradiated with 50 to 55 gray. And we put the patient on second-line hormonal therapy program with ketoconazole, leucine, and estrogen. We're extremely aggressive because it's a situation that can be very aggressive. Doesn't have to be. Unfortunately, prostate cancer is like that. So there are people with bone lesions with a PSA under 10 where the cancer is entirely aggressive and they do very well. But you need to be aware that this could be the sign of a disease that's behaving like a Gleason 10.
I didn't tell you that my Gleason is 8.
Okay. Yeah.
He mentioned for those in the back, his Gleason is 8. I'll get back there in just a moment. I have a gentleman here first.
I look at all your videos and appreciate them, and thanks for being here. Are there other centers in the United States that you've become aware of, besides Sand Lake, that do similar work, either in imaging or in treatment, radiology treatment?
Well, right now, because of capacity problems, Sand Lake is only taking referrals from my office and Dr. Dottoli. There is a competing technology, a choline PET scan, that is not quite as sharp as the USPI Faraheen, again, but it appears to be good enough for the purposes. And I know that there has been the choline PET at UCLA, although at the meeting, at PCRI meeting, I heard that they may be in trouble with continuing that or not. Mayo Clinic, Dr. Kwan at the Mayo Clinic has the choline PET, and I've had a patient have a choline PET done, I believe, at the University of Kansas. And the patients that have the choline PETs done and radiation guided by the choline PET have done quite well too. So I would regard that as a reasonable alternative.
Not quite as good, but
good enough.
Good enough.
You know, Churchill is one of my favorite guys, and he has all these great quotes. And one of his great quotes was, you know, Eisenhower was fussing over making the Normandy invasion perfect, and his quote was, "Perfection equals paralysis." So it's good enough to get the job done. Yeah.
My question is this. You mentioned 4 supplements, vitamin D, pomegranate extract.
Yeah.
What were the other 2?
Resveratrol and curcumin.
Thank you.
Well, we have the ladies want to ask something here.
I'm asking for my father. I wanted to get your recommendation. He had a radical prostatectomy 8 years ago. It's hormone resistant. He's tried pretty much every combination, and it's now metastasized to the bladder. So I just wanted to see what you thought in terms of, he hasn't done radiation or chemotherapy yet.
There's an echo here, so that your voice was overlaid one after another, and I couldn't hear what you were saying.
Okay, let me see if I can paraphrase it. Your father had a surgical radical prostatectomy. He failed chemo. He failed hormone therapy. He did not fail chemo at this point. Hasn't taken chemo, and he has metastasis to the bladder. And in 5 minutes or less, how can you cure him?
Well, this is the situation where we use our second-line hormonal therapy protocol, which uses ketoconazole, leucine, and transdermal estrogen.
He's already tried those.
What'd she say?
He's already done the second line. He's already done ketoconazole leucine and estradiol. He's done that secondary hormone therapy.
Have you had radiation therapy to your prostate bed?
No, he has not.
So it's really important to know where your cancer is located. And this is a situation where if the cancer is only adjacent to your bladder, a skilled radiation therapist might be able to do a job here because the bladder itself is very resistant to radiation. With routine radiation therapy for prostate cancer, the bottom of the bladder gets hit anyway. And while you get urgency and some urinary difficulties, they're transient. The bladder fixes itself. And so this is the classic example where you want to use the best technology available here to find the extent of the disease and then go after it.
Could you please go into more detail about 4 supplements, especially trichomin?
Especially what?
Trichomin, he said. That's not one of his 4 supplements.
Curcumin.
Curcumin. Curcumin is the yellow pigment in the spice turmeric. And it's one of the hottest things in medicine today. If you want to get a good sense of that, go to www.scholar.google.com and put in curcumin and cancer. Try curcumin in Parkinson's, for example, or curcumin in heart. And you'll see this very extensive literature on this. Well, to give you an example, in the laboratory, it's one of the most effective drugs for the treatment of Parkinson's disease, and seems to arrest the progression of the animal models of Alzheimer's. In cancer, cancer is stimulated by inflammation, and this is the first compound to target one of the major inflammatory pathways that stimulate cancer progression. The use of it as an anti-cancer drug was pioneered by M.D. Anderson, which used high doses of curcumin to treat cancer of the pancreas, which is the most rapidly lethal cancer that humans get. And they showed that very large doses could be tolerated well, and that in certain cases they could arrest cancer of the pancreas. It also looks promising in cancer of the colon. So using the discoveries at MD Anderson, we've tried it in prostate cancer, and at reasonable doses it appears to be able to slow the growth of prostate cancer in quite a few men. The major side effect of curcumin is diarrhea. Some people get an upset stomach, and it appears to be very individual. Some people can tolerate astronomical doses of curcumin without a problem. Others get diarrhea with a small dose. So we usually start people off on a low dose and escalate it gradually to find out the maximum dose someone can tolerate without their intestinal tracts complaining.
By show of hands, how many people would like the doctor to spell curcumin?
C-U-R-C-U-M-I-N.
Okay, we got you still want more questions, Doctor?
No, I'd like to go on and then we can...
Okay.
Yeah.
We all appreciate that we all have questions we'd like to ask the doctor, but he has more general information he'd like to give. Then we'll probably get a couple of questions later. Is that correct?
Yes.
Okay.
Okay, now I mentioned the whole problem of cardiovascular disease. And even though we're very aggressive, that's still a major problem even for us. And so I'd like to talk about the management of cardiovascular disease in prostate cancer and why it's a problem. First, there seems to be a link between having heart disease and getting prostate cancer. If you've been diagnosed, if you had a heart attack, you're much more likely to have prostate cancer than someone who didn't have a heart attack. If you're diagnosed with prostate cancer, you're much more likely to have a heart attack than someone who doesn't have prostate cancer. Diets that reduce cholesterol reduce the risk of prostate cancer. Statins that are used to lower cholesterol reduce the risk of getting prostate cancer. This first came apparent in a study from the Netherlands where men who'd been on statins for more than 4 years had a 50% reduction in the risk of getting prostate cancer. This study was repeated at Johns Hopkins in their School of Public Health, and they got the same 50% reduction. 2 different continents, 2 different institutions. In the laboratory, LDL, the bad cholesterol, fuels the growth of prostate cancer. So the first problem with heart health is there really is a link between heart disease progression and prostate cancer development that starts with your bad cholesterol. Second, if you go on hormonal therapy, 2 things happen that dramatically increase the risk of you having a heart attack or getting diabetes or hypertension. The first fundamental thing is that insulin starts working less well. You become insulin resistant. So you become suddenly like someone who has the genes for adult onset diabetes. This means that your body thinks it's starved of sugar when you're overeating sugar. So on hormonal therapy, men start craving sweets and carbohydrates. They start gaining weight. But the incoming calories go to fat, not muscle. And so your people's waistlines start to balloon out. They start getting the blood sugar, fasting blood sugar that's sneaking up. And if they're on hormonal therapy for more than a year, a significant proportion of them will start becoming diabetic. And of course, diabetes has terrible consequences for heart attack, stroke, and kidney failure. The other thing that happens when testosterone is low is your arteries become stiffer. Now, in a young adult, when the heart beats, a pulse wave comes out along the major arteries. And as this pulse wave passes, the arteries, which are elastic, expand like a rubber band. And when the pulse wave passes, they snap back. And this expansion and contraction helps minimize the pulse pressure, the difference between the high and low number. So in someone at age 20 who's in good health, the difference between the top and the bottom number is going to be 40 or less. As a part of normal aging, the arteries get stiffer and stiffer. And as a result, that the arteries can't expand. And so the pulse pressure expands. So instead of being 120 over 80, you become 130 over 80, 140 over 80, 160 over 80, 180 over 80. And that increasing systolic hypertension has dramatically increases the risk of a heart attack or stroke. To put numbers on it, if your top number, the systolic number, is under 120, you have no risk. But for each 15 points above that, you double the risk of a heart attack or stroke. So just going from 120 to 135 doubles the risk of heart attack or stroke. Going from 135 to 150 doubles it again, 400% increase. This is not controversial. This is part of there are national standards of practice, and these figures are right out of that document that every family practitioner gets. As an aside, most family practitioners I deal with are ignoring this problem. It's very uncommon. Most people come in with a blood pressure 135 over 80. The family doctor says, "Oh, you don't have a problem." When there is no controversy that has doubled the risk of heart attack or stroke already. Now, if on hormonal therapy, your blood pressure, you need to get a blood pressure count. And a couple times a week before you get out of bed, you should be measuring your blood pressure. And we need to keep it under 130. Because blood pressure and cholesterol and all these things add up together A cholesterol is more dangerous if it's coupled with a high blood pressure. So here you've got prostate cancer, and the patients who get it tend to have high cholesterols. Then they get put on the treatment, hormonal therapy, which causes hypertension and diabetes. So you see how, over time, cardiovascular deaths get to be a huge problem in a prostate cancer clinic. And you can prevent this from happening by intervening early. Now, fortunately, the Mediterranean heart-healthy diet has been shown in randomized controlled trials to reduce the risk of diabetes, to reverse early diabetes, to prevent insulin resistance, and to help with blood pressure. So it's the place to start. But most patients are going to need a prescription drug for blood pressure control. And here's another place where things go wrong. Blood pressure medicines vary. Some of them actually stimulate prostate cancer, and others suppress. So calcium channel blockers, which are widely used for hypertension and for irregular heartbeat, make the prostate cancer immune to hormonal therapy. It dramatically lessens the effectiveness of hormonal therapy. And I can't tell you how many times I've got someone sent to me, they're hormone resistant, and I look at their medicine list and they're on Norvasc. And just getting rid of the Norvasc can often dramatically improve the patient's control and responsiveness to the hormonal therapy. Simple things. What antihypertensives are good to use? Well, there are two drug classes that are really great. One is an ACE inhibitor, and ACE inhibitors are now very popular because many of them are generic and they're cheap. And the ACE inhibitors not only control blood pressure, they cause a 30% reduction in the risk of diabetes. They reduce the risk of getting atrial fibrillation. They reduce the risk of heart failure. And they can cause PSAs to drop. A related drug class, angiotensin receptor blockers, called ARBs, are even more effective at all of those things. They're better at reducing the risk of diabetes, they're better at reducing the risk of heart failure, and 25% of the patients will have a PSA response. They block angiotensin, and angiotensin is one of the hormones prostate cancer uses when testosterone is not available. So by treating your hypertension with an angiotensin receptor blocker, you're preventing one of the major pathways for hormone resistance to develop. So those are the two that are my favorites. Beta blockers are also widely used. And beta blockers, men on beta blockers are less likely to get prostate cancer. And there's some evidence there's some anti-cancer activity from the beta blockers. However, beta blockers prevent you from burning fat from energy. And they cut the top 25% off of cardiovascular performance. So your maximum heart output gets cut down by about 20 or 30%. So I use beta blockers, but only with care. There's some very special beta blockers that lack these complications. And the best one right now is Bistolic. B-I-S-T-O-L-I-C. Not a generic, and so the insurance companies sometimes make you battle. But it doesn't affect the ability to burn fat, and it doesn't affect maximum heart output. So these are important issues. Management of hypertension. Thiazide diuretics are widely used for hypertension. And in general, it's safe to say they are the cheapest and most effective single drug class. The only problem with using them in prostate cancer is they increase the risk of diabetes. And so if you're on hormonal therapy, I try to stay away from the thiazide diuretics if possible. You may get better blood pressure control, but you'd have to work harder for the blood sugar. Diabetes is a big problem for prostate cancer patients for the reasons we've all talked about. There are drugs available to treat diabetes. The best oral drug for diabetes in the prostate cancer setting is metformin. Metformin is an interesting drug. it really is an herbal remedy. It started out as an extract of French lilac, and it started to be used in diabetes in Europe in the 1300s. So metformin is a semi-synthetic analog that is patentable and is the most widely prescribed drug in the world today. And so it would be where I would start if the blood sugar can't be controlled by other means. Now, for the most difficult medicine I ever have to recommend, taking a pill is easy, but all the problems we've just talked about are dramatically lessened if you exercise. Now, I've discovered that there are men who come to see me who are exercising. That's one group. There are people who aren't yet exercising but are motivated and can exercise and do. And then there are a large proportion of men in their 60s who just can't imagine exercising and will not do it. They could die before they'll go exercise. One fellow, he's a great guy, I enjoy meeting him very much, but he told me that exercise was beneath his dignity. Men in his family do not sweat. So, we actually have randomized controlled trials to show that exercise dramatically lessens the damage hormonal therapy will cause. And if you're doing intermittent hormonal therapy, you'll recover normal testosterone and function much faster off hormonal therapy if you stay thin and you exercise. And this isn't a matter of someone just talking about apple pie and motherhood. There are clinical trials, and we actually know some of the details. So let's talk about the details. It turns out you need to do both aerobic exercise and muscle building, weightlifting. So aerobic exercise for 30 minutes a day is the starting point for general health. Let's look at the big picture. One of my favorite studies was the HOPE trial, which took 2,300 men and women between 70 and 90 years of age. And they looked at 4 health practices. Do you smoke? Yes or no? Exercise 30 minutes a day? Yes or no? Mediterranean diet? Yes or no? Let me see. And moderate alcohol consumption. Each one of those reduced the overall death rate by about 20–25%. So, exercising for 30 minutes a day reduced the death rate by 20–25%. Overall death rate, well, death rate from heart disease and cancer was reduced by 30 minutes of exercise. Well, those are 4 things that you can do. If you did all 4 right versus all 4 wrong, there was a 75% reduction in death rate. Again, Mediterranean diet, exercise. What are they talking about exercise? As little as 30 minutes of gardening. Gardening would do it. And when I first read that, I thought, well, gardening, how's that as an exercise? Then I go out and help my wife in the tomato patch and realize that it's almost as hard as being on a treadmill to help her collect her tomatoes. So 30 minutes of exercise. If you go to 60 minutes, there's an incremental benefit. Go to 90 minutes, there's even more. But there's a diminishing return. Instead of going up like this at the time, it goes like this. So going from 60 minutes to 90 minutes doesn't buy you all that much more compared to going from 0 to 30 minutes. And I've tried this, and I find it nearly impossible to ever get a patient to do 90 minutes of exercise and have any other interests outside of the health call. But there are some gym rats. So aerobic exercise. Now, aerobic exercise alone is not enough. You need to maintain muscle mass. Hormonal therapy causes you to lose muscle power. And I see this in several problems. One, rotator cuff. The shoulder is held together by some small muscles called the rotator cuff muscles. And they hold the shoulder in place, so the major muscle power of your pectoralis, your deltoids, the lats in the back can act. But if the rotator cuff muscles have atrophied and you need to call on your shoulder girdle for something, you'll rip your rotator cuff muscles and head to surgery. And this is a big problem for men who don't maintain the rotator cuff. Fortunately, you can just go up on the internet and enter the rotator cuff, and YouTube will give you a set of videos on how to maintain your rotator cuff muscles. So that's an important part. The other thing I see is the muscles that people use to get up out of chairs or go upstairs or to catch themselves if they fall. So you know how to get up out of a chair. Well, the muscles here often get weak, particularly in men over age 80 who are on hormonal therapy. This gets to be a huge problem. In fact, I do not use Lupron over age 85. It's just a catastrophe. In fact, we just did a video on that. The other movement is this one. If you're falling, what are you going to do? You have to catch yourself. And the muscles here and the balance tend to go. And so, particularly men over age 80 on hormonal therapy who don't exercise, they can't catch themselves if they're about to fall. And because their bones are weak because they've been on hormonal therapy and they're vitamin D deficient and their doctor didn't bother to put them on vitamin D, when they fall they break a bone. And then they end up in the nursing home and they never get out. So you need to do weightlifting. Now, you can only stress a muscle group once a week with weightlifting. Typically people say do 2 sessions a week. What they're really saying is it takes 2 sessions to do each of the muscle groups. So you might say take one day for your upper body where you do your biceps and your deltoids and your rotator cuff muscles. And then the next day you do your leg muscles, you do your lunges are a really great one. You just go out like this, knee over up to the toe. Lunges, squats. Squats are a wonderful exercise. And there's actually clinical trials in men over the age of 90 to show they can be taught to do squats and that within 9 weeks the squats will dramatically improve their balance and reduce the risk of fall. But you can't go and do a squat on your own. You need someone to teach you how to do it without injuring yourself. If you want to do it yourself, probably the best book to read about how to do weightlifting safely is called Starting Strength by Mark Riptow. And he goes over the full 5 basic weightlifting exercises. His discussion of the squat is the best I've ever seen. He also has videos on YouTube. No Nonsense Guy. Best biomechanics discussion of that I've ever seen. So resistance exercise is also an important part. And so over time, the patients in my clinic who do the best are the people who have the attitude in life that if a problem comes up, they will identify what they need to do and do it. Ironically, this is the formula for success in life too, isn't it? We live right now in a time in America where unexpected changes and challenges are being thrown at us individually and as a country. And I think that we'd be much better off if the people in Washington had the attitude that they need to identify what they need to do and get on with it, fighting amongst themselves. But as patients, this is very much an issue. You need to get the attitude that you've been dealt a tough set of cards, but you can do well if you be methodical, identify what the problems are and what you need to overcome them and put it in motion. No doctor can do this for you. So the best patients I have are the best patients because of the type of person they are, not the kind of doctor I am. So let's step back now and take questions. I tried to cover things that you're not going to hear from anyone else. So I'm ready to answer questions on any of this, or things outside that. I would prefer if you not give me your personal histories, but couch the term in more general terms. So I'm not just answering a question for you, but talking about other people's problems too.
Dr. Myers.
Yeah.
Wonderful. Thank you for coming. I really appreciate your visits and your wisdom. My question's kind of related to your supplement choices. Those are, well, they're pharmaceuticals or phytoceuticals. Is there anything in the Eastern medicine catalog, whether it's meditation, Tai Chi, etc., that you ever have seen had an effect on prostate cancer?
Oh, well, Resveratrol was a standard part of the Chinese medicinal formulary. The commercial Resveratrol comes from the Japanese knotweed, which grows wild in China and has been used in Chinese medicine from time immemorial. Curcumin was one of the standard parts of Ayurvedic medicine from India. So, however, I would say it took Western science to learn how to give them in doses and schedules that were effective. Tai Chi is great exercise for balance. It doesn't do much for muscle, but it's great for balance and inner peace.
Yes, you mentioned resistance training, and I think in your book you mentioned creatine. Would you recommend that for someone over 70, and how would they go about doing that?
So there have been, sarcopenia is muscle loss. You know, osteopenia is muscle bones, sarcopenia. So there's an enormous research on how to treat sarcopenia. And it's important either immediately before or after exercise to take in 20 grams of protein. The highest quality protein available is whey protein. Egg is second. So if you're at home, 3 or 4 egg whites, 3 egg whites would be 20 grams of protein. Whey protein, my own personal preference is a brand of whey protein called Isopure. Isopure whey protein's available from Amazon. I like the vanilla. It dissolves in very rapidly and easily in things. So 20 grams of protein, that's the most important thing. Creatine also stimulates new muscle protein synthesis after exercise. And the dose of that doesn't need to be taken with exercise, but 2 grams twice a day. And the brand I prefer to use is Twin Labs Creatine Fuel, and it's dirt cheap. The maximum daily dose is somewhere between 4 and 5 grams, and so that's what you need of that. The other major stimulus for new muscle formation, a group of amino acids called branched chain amino acids. That the muscle you can use for energy, but also it stimulates new protein synthesis. The most common branched chain amino acid is leucine. So if you go to any store specializing in weightlifting supplements, branched chain amino acid supplements are available. One of the ones that's very popular with my patients is called Purple Wrath. It's for these muscle building types, too many barbells dropped on your head. That's probably, but there are a wide variety of brands that sort of do this. Leucine is broken down in the body to hydroxymethylbutyrate, called HMB for short. And HMB in randomized controlled trials stimulates new muscle formation almost as much as testosterone. And so when Twin Labs has an HMB supplement and 1 capsule twice a day in combination with creatine. And the protein is very powerful and will work in the absence of testosterone. Now the final interesting thing, Zytiga is a hot new drug because it blocks the formation of testosterone inside the prostate cells. Well, that was a real discovery, that prostate cancer cells had all the machinery that was present in your testicles. But we now know that that's true for other things. So muscle, if you do heavy weight with your muscle, especially if you do while the muscle's lengthening. So you're doing bicep curls and the weight's too heavy and you're finding it's coming down like that. After that session, your muscle will make testosterone inside it. Large amounts of testosterone are made within the muscle. So that even if you're on hormonal therapy, you can generate enough testosterone to develop major muscle mass because of this. And I only found this paper because I had a patient came back to me. He's the ultimate positive attitude guy. He could make Norman Vincent Peale look like a pessimist. And he'd been on chemotherapy for more than 18 months, and hormonal therapy for 3 years continuously. And he came back and his shoulders were like this. I mean, thick. And I said, what have you been doing? And his biceps. Well, he could press over his head 120 pounds. I don't know whether you've ever tried that, but that's an amazing feat. And he did this while he was on treatment. How the hell did he do this? I mean, if you were dependent on exogenous testosterone, well, he was doing the H&B, the creatine, and the whey protein, but he was pushing heavy iron. And I'm sure that whatever metabolic machinery is required for testosterone, he had more of those genes than other people might have had. But it's really important to know this is possible. That you really can maintain maximum function. I have another guy who's been on hormonal therapy for several years and is a ski instructor at Telluride who does the double black diamond slopes at age 70. He teaches them. But it requires attention to detail. Okay, next question.
Doctor, thank you for your wonderful blog. Thank you for your wonderful blog. I feel like you're an old friend. I've been watching you so long. But in one of your recent blogs, you mentioned a company called Caris Life Sciences, and I looked it up. And that concept of treating cancer by determining or predetermining a possible, more effective drug was appealing to me. Could you expand on that?
Yes. So going forward, I think this is one of the major things that's going to transform management of advanced disease. That 24 patients I lost in 2010, it bothers me. I can't sleep at night because I lost the battle. So this is going to transform that. So what they do is, we know the genes that govern responsiveness to most of the chemotherapy agents and most of the fancy new drugs coming down the pipe. So it's possible to test a tumor and pick a drug that matches the genes in the cancer. They don't always match what you think they would. And so all this started for me 6 years ago. I had a patient come to my clinic with cancer of the Cowper's gland. The Cowper's gland is this pea-sized gland near the tip of the prostate that makes the clear liquid that comes out of your penis before you ejaculate. It's designed to lubricate the urethra so the sperm can pass easily. He had cancer of the Cowper's gland. Well, there are only 34 cases in the world's literature. This is the ultimate rare cancer. And so there's no guidance about what to do. And he'd been seen at Mass General, and they'd done surgery. They'd done radiation therapy. They did platinum and Taxotere. And when those things failed, they told him, well, we can't treat you anymore because we only do evidence-based medicine and there's no evidence. We can't do a clinical trial. We could treat you on a clinical trial, but no one's going to do a clinical trial with a disease that rare. So there's nothing we can do. Meanwhile, they had biopsied his cancer and tested all the genes that would govern response. But they couldn't act on it because there had been no track record. So he had lung metastasis and liver metastasis. And so I looked at the list of genes, and I'm a clinical pharmacologist, so this is right what I've been doing my whole life, is looking at this. So I picked up a 4-drug combination, and 8 weeks later the lung lesions had disappeared, and all the liver lesions disappeared but one. We froze that one liver lesion, and he was in remission. And then a year later the cancer comes back again. I pick another different drug combination. He goes into another remission. Then Keras DX comes along, and I do 2 different rounds with him now. And so he's done 4 rounds, and he's now 6 years out. And his cancer grows explosively when he's not on treatment. After Mass General said they didn't have anything to do, using gene testing. And I've done a handful of patients with prostate cancer with Keras, and it's been transforming. The responses are dramatic. Like, for example, they can tell me whether the cancer is still driven by testosterone. They tell me is the testosterone receptor overexpressed, and that can tell me whether Zytiga will work or not. So I'll give you another case. This is a young guy from Atlanta. No response to hormonal therapy, no response to second-line hormonal therapy, short response to Taxotere, and then explosive pulmonary metastasis, just doubling in less than 2 weeks. He went from nothing in his lungs to having a hard time breathing in 3 months. And Keras DX testing came back. Abraxane. Well, Abraxane is a drug used for breast cancer. No evidence that it would work for prostate. Somehow the insurance company bought it, the idea, and 90 days later his lung lesions were gone. He got about 14 months of control. He's now on the 2nd generation of treatment dictated by Keras DX. So for the advanced, difficult to treat patients, already these people have it in place. So we're setting up a program to make this very efficient. Get the tumors biopsied and do it with Keras DX. And I'm working with them on expanding the list of genes to cover more information pertinent to just prostate cancer. So this is one of my major emphasis going forward. I think it's really important.
I'd like to ask you this question with your perspective of seeing what happens after a long time for prostate cancer. Unfortunately, I have a non-symptomatic, non-nodular Gleason 6 score. And at the meeting that I attended this weekend, many of us were at, the oncologists say, follow the 6, while the people that were the urologists say, do a prostatectomy. And what I'm wondering is how many people with 6s have you seen metastasize and cause significant problems? Is a grade 6 really a very good indicator of who's going to get into trouble or not? Or is it something that you would say that early treatment makes a lot of sense? As a person recently diagnosed with it and just beginning to attend these meetings and having a medical background, it's very, very confusing when you hear 2 sides of the story.
So Gleason 6, this is 3 plus 3 equals 6, there is no clinical trial ever published to show that surgery or radiation confer survival benefit. So that's one level of answer. So it truly is experimental. It doesn't say not to do it, because I do things that are certified by randomized controlled trial after discussing with patients. But that sets the stage. Now, Gleason 6s aren't all the same. There are maybe 75% of the Gleason 6s are sheep. About 25% are wolves dressed up like sheep. So what makes a Gleason 6 not a sheep? Well, the first thing you have to worry if the cancer is more than 1 centimeter in diameter, because then it is at a higher growth rate than most Gleason 6s. Second, if you do a color Doppler ultrasound, and Duke Bond in Ventura is the best guy in the world to do this, so he's right nearby. If he says that Gleason 6 is highly vascular, then that's a wolf dressed up like a sheep. If it shows invasive potential, if it's broken through the capsule and moved to the seminal vesicles, or if it's metastatic to lymph nodes, then that obviously indicates that it's invasive, and 6s aren't supposed to be invasive. And so it really isn't a 6, it just looks like a 6. So where on that continuum are you?
I have an elevated PSA, which was used for the test originally for biopsy.
Hold on just a minute until I get you the mic. I'm sorry.
Yeah, because I actually heard what you said, but no one else did.
I have an elevated PSA with prostatitis, and I've been biopsied, and it's not nodular. And I've had a Doppler of my prostate, and it's non-detectable on Doppler. There was no indication as to where to take a biopsy. It is in the apical area, which I guess some people feel is more concerning, but still, my urologist wants me to have a prostatectomy, and then I went ahead and I saw Dr. Lamb, and a lot of people know here, with Scholes and the like, and he says we should do watchful waiting.
Okay, so, I mean, those of you at the PCR meeting heard the question Mark Moyad asked me about, well, why do some people not like me? and you're about to hear why that is so, why I make some people piss off at me. I'm 68 years old. I've done most of the goals I have in life. I can afford to be honest with you, and that makes people uncomfortable. Surgery has no role to play in an apical lesion. Surgery for an apical lesion is likely to leave you with positive margins and will certainly leave you incontinent. Radiation therapy, if you want to get rid of it, radiation therapy in good hands is clearly superior to surgery for that purpose. So you shouldn't be talking to surgeons at all. They're going to mess you up big time. Now, I just made a lot of surgeons angry at me. Some deal. Who did the color Doppler?
It wasn't a color Doppler, it was done by Richard Van.
Oh, okay. Well then, you're an excellent candidate for active surveillance. And there's no evidence that surgery would be a benefit and likely to leave you incontinent. And so I think you're an ideal candidate for active surveillance. Now, I would say that, remember the growth arrest program I talked about with Avadon and the 4 supplements? So that's what we do. We don't do active surveillance, we do growth arrest, in which we optimize people's general health and do these additions. And working with Duke Bond, we've seen small 6s disappear over a period of 2 or 3 years. The 6s you can see disappear, and you stick a needle in where they were and they're not. So I think you should, and also the folks at Johns Hopkins have shown that you can do active surveillance safely. At Hopkins, when they did active surveillance, in the 25% of the cases, the cancer did progress and need surgery. But in no case was the surgery too late. So I would think that in this setting, active surveillance is the established treatment, and surgery would be questionable, and radiation therapy a research question without proven efficacy. Okay.
Thank you very much for being here, Dr. Myers. When you have a rising PSA and you've had a radical prostatectomy and you're just failing hormone therapy when you've gone through Casodex, Lipron, Dilutamide, the rest of them, any suggestions?
Have you had ketoconazole?
Not yet.
So ketoconazole is the next thing to do. You could do ketoconazole alone, or the combination I discussed at the PCRI meeting. Ketoconazole, unfortunately, is done poorly by most medical oncologists. And we discussed at the PCRI meeting how to do it properly. We've done newsletters on ketoconazole that are available on our our site, but in summary, ketoconazole needs to be done every 8 hours by the clock with an acid beverage. The drug doctor has to look through a set of drugs that might interact adversely with ketoconazole, so it's a lot of work on the doctor's part. But ketoconazole has the same response rate as taxotere.
When you know that the cancer is in the lymph nodes,
yeah,
then that's still a good
I'm sorry, I can't hear what you're saying.
When you know that you have Mets in the lymph nodes?
Oh, you're asking whether you have oligometastatic disease. Well, certainly that should be looked at.
Thank you.
Yeah. Then go back to the beginning of my talk and go get the most important thing is to find out if you have bone lesions. The F-18 bone scan is available in several places in the Los Angeles area. And if your bone scan is negative, then it is lymph node disease, then you need lymph node staging, and you possibly could get a remission that way. Although we would use ketoconazole along with the radiation in that setting.
I'd just like to make a comment about exercise. You are never too old to exercise. I'm 84, and we have.
You don't look 84.
We have an instructor at our health club in Whittier at the shopping center, and we celebrate her birthday every year. She's been teaching as an instructor of exercise, and next Tuesday she's going to be 93, and she's still going full blast.
Thank you very much for that. Should I give the questions a break and back to you, or you want more questions?
Why don't we do one more question, then I'm getting kind of tired.
Okay, one more question, and then we got to get him to the airport. Anybody want the last question? I can't believe it. Oh, here we come. Larry, come on up here.
Greetings and thanks again for coming. I'll ask you a question I ask most of our guests. What's new and exciting on the horizon within our lifetime? Prostate cancer. New treatments, new therapies, new drugs.
Well, of course, the gene testing in the oligometastatic disease of the drugs in testing. I think there's 100%, the first time in my life, there's 100% consensus about a hot new drug that was called XL184. And it's one, you know, we talked about gene testing identifying targets. Well, this is a drug that was actually developed to target the genes expressed. So it's a member of a new drug development strategy of finding out what the cancers are expressing and targeting it. This drug targets c-MET, C-MET, which is an oncogene found in prostate and other cancers. And it targets the receptor for the major angiogenesis protein called VEGF. And in the phase 2 clinical trial is when you know the dose and you're testing a group of 20 or 30 patients to see if the drug is active. And in a very large proportion of cases, the men with bone disease, there was complete disappearance of the bone disease. With mild side effects. And I've been in this business since 1971, and I have never seen a drug this exciting.
I want to say something just about that complete disappearance of the bone disease.
Yes, not common. I will say that it's not common, but the ketoconazole leucine estrogen combination has done that. We've seen up to 40 bone lesions disappear with that combination, but that's a combination, not a single drug, and it's not nearly as frequent in our combination as it is with a single drug. So this is going to, and it's targeting an entirely new target, so there's going to be no cross-resistance with any previous drugs we have. It's available oral and intravenous, so yeah, exciting.
When do you expect that to be available, Dr. Myers?
Well, they're being allowed by FDA to target pain relief from bone lesions rather than survival, which is going to dramatically speed the development. It should be a year to 18 months, 12 to 18 months.
Okay, we would really like to thank you tonight. It's been wonderful, intelligent, amazing. Dr. Myers is here with his wife, and we're going to run him to the airport, but we really want to give him a token of our appreciation. And it's not money. But we know that he's a very busy man. He exercises every day. He has to get to the practice in a hurry. So he can get there in a hurry, we have his coffee cup that'll fit in the car so that he can drive. And his wife is here, so he doesn't get one, he gets two. Dr. Myers, thank you very much. As I said before, he can't take questions now because we've got to get him to the airport. So thank you for coming. We'll see you next month.